Greetings. During the past several months, we've learned a great deal about patients suffering from the coronavirus, including the serious morbidity and mortality associated with the disease. The daunting challenge of saving patients who develop severe acute respiratory syndrome coronavirus is just one clinical challenge, but the necessity for urgent elective surgery introduces a whole new level of complexity. Here are my disclosures. So, coronavirus and thrombosis, what do we know so far? We realize that the virus-induced inflammation triggers a cytokine storm, causing tissue factor release, thrombin generation, and fibrin formation, and this fibrin is designed to coat the virus and prevent its spread and replication. Now that's a great mechanism, but it has one unfortunate side effect: thrombosis. The activation of thrombin induces a hypercoagulability that can be measured with a D-dimer and fibrin split products. Deep vein thrombosis, pulmonary embolism, stroke, arterial thrombosis, all may occur. But we have to remember that microvascular thrombosis is occurring all over the body and may result in organ insufficiency or failure in the lungs, liver, kidney, or even brain. The fibrinolysis that is a reaction to the thrombosis on the basis of the body produces fibrin split products. And a DIC picture can result in thrombosis or bleeding depending on the consumption of clotting factors and platelets. And these, of course, can be measured by a prothrombin time, partial thromboplastin time, and a platelet count. What are the symptoms? They can be mild and flu-like, or you could have a serious infection with systemic sepsis, organ failure and death. Pneumonia and respiratory failure commonly occur, as well as deep vein thrombosis with swollen, painful legs or arms, eventually leading to the post-thrombotic syndrome if the patient survives the illness. Pulmonary emboli can result in respiratory failure and death or chronic pulmonary damage down the road after recovery. Stroke with paralysis and death have also been observed. We realize that the presence of additional risk factors compounds the likelihood of a poor outcome in these patients. And this COVID-19 picture mimics, if you will, Virchow's Triad. And these are the three factors that are associated with especially venous thrombosis, and stasis, endothelial dysfunction, and coagulopathy are all essential hallmarks of this disease and can result in a variety of problems. One of the things that's important to remember is that venous thromboembolism or arterial thrombosis is seen in nearly 40% of ICU patients compared to only 2 or 3% on the ward. So getting into ICU connotes a serious escalation of the disease, whether or not they actually have to be placed on respirators. Remember that COVID-19 is an endothelial illness involving the systemic vascular tree. And investigators have postulated that the lung environment is prone for local vascular leakage leading to angioedema, as can be seen in this cartoon. They hypothesize that a bradykinin-dependent local lung angioedema via bradykinin receptors is an important feature of COVID-19. Blocking these receptors and inhibiting kallikrein activity are postulated to have an ameliorating effect on early disease and might prevent acute respiratory distress syndrome. In addition, this pathway might indirectly be responsive to anti-inflammatory agents. And in that regard, a number of investigators have employed early and heavy-dose corticosteroids to try to blunt this process. Here we see another cartoon which is designed to show the complexity associated with multiple systems activation as a result of the coronavirus problem. Cytokine storm is a key feature of this, and sometimes it's massive and activates platelets and other clotting factors. This can damage the endothelium, and the neutrophils can express tissue factor, which further activates clotting. Neutrophils' extracellular traps can form, and these contain damaged DNA and other products, including histones and chemical mediators, which can together also block and damage the endothelial surface. Reflecting on all of these changes that occur in multiple locations, both in the inflammatory and clotting pathways, one is reminded of the non-anticoagulant effects of heparins and related agents. The polyanionic nature of heparins binds to proteins and is an effective inhibitor of the viral attachment. So looking at all of these various effects, it's obvious that the use of heparin, or low molecular weight heparins, are one of the cornerstones in trying to blunt the side effects of this disease and also block the pathways both of inflammation, complement and kallikrein, as well as clotting, fibrinolysis, and platelet activation. We know that when surgery is introduced into the picture in the presence of this virus, that the result can be a very, very serious and, if you will, an explosive picture. Let us take a look at the Caprini score, which is a way to evaluate these patients, which I think is a very essential element. And some have said, why bother to do this? Since all of these patients are at high risk, so we need to put them all on heparin. But there's a matter of degree, and there are some very important aspects to be considered. So when we take a look at the Caprini score, it's a thorough history and physical composed of 40 elements. And we know as the number of elements or risk factors goes up, the incidence of DVT increases. We also know that risk factors have different powers to cause a thrombosis. Bed rest, for example, is not as powerful a risk factor as a past history of thrombosis or cancer. So that the power of these risk factors also factors into the equation. By combining the power of individual risk factors as well as the number of risk factors, we come up with a score. And that score has been associated in a linear or nonlinear fashion to the incidence of clinical venous thromboembolic events. And here we see a typical pattern in general surgical patients. Now, it's very difficult to collect all this information, and especially I've been told by first-line workers as we have these patients coming in. Oftentimes they're very sick, they're an emergent nature. We don't have time to sit down with them and talk about 40 questions. Well, my colleagues in our group have come up with a very important patient-friendly assessment for the disease. And as you know, when you go to the dentist, you have to fill in your health history. And if you're brought to the hospital sick, you're usually brought by the family, and the family can help fill out this form. The form is in multiple languages around the world, and it's in very user-friendly language so that it can be easily completed by the patients. And then finally, once that form is filled out by the patients, then it can be completed by the healthcare provider that's responsible on admission for the history and physical. Now, for surgical patients, it's important to prospectively collect this score. And then in terms of filling it out, we have additional risk factors now that we have the coronavirus. And we score all of those people who are positive with an additional 2 points and add an extra point if the D-dimer is over 2 times normal. Remember, you have to add the surgical procedural risks to that, so the risk of a major colon resection is different than that of a routine appendectomy or a small procedure. The score has to be updated during hospitalization as complications occur. Oftentimes, a patient will come in with a simple problem, let's say an acute appendix, and then postoperatively the patient will leak, have another procedure, need a central line for antibiotics to be infused, maybe get a pneumonia in addition to that. So the patient becomes from a very low-risk patient to a very high-risk patient. Now let us talk about the surgical procedure, because the surgical procedure is an embodiment of Virchow's triad. And as you know, over 100 years ago, Rudolf Virchow described a triad of factors associated with the development of venous thrombosis. And we know that when the patient is put to sleep, they've given a muscle relaxant in order to intubate the patient, and that causes venous stasis due to calf muscle paralysis. The veins become overdistended because the blood is not flowing out normally, but the arteries are continuing to pump blood in. In addition to that, hypercoagulability occurs not only because of the basic disease and underlying pathology, but also the metabolites of the muscles are being secreted into these dilated venous segments, and there's nowhere for it to go, or the very slow flow out of the leg. And that creates a very sort of witch's brew for producing a thrombosis in these vessels. And that's why it's very, very important to use pneumatic compression during these procedures. And of course, the time of anesthesia and the magnitude of the procedure all contribute to this, if you will, witch's brew. Now, recently we put together some guidelines from the American Venous Forum regarding considerations for prophylaxis and treatment of venous thrombosis. Patients all should be scored on admission and rescored during hospitalization with the Caprini score as we previously described. Baseline blood count, platelet count, prothrombin time, partial thromboplastin time, D-dimer assay, and fibrin split products should be done initially and serially, especially if the patient's developing complications. All patients should receive heparin or low molecular weight heparin. Consider doubling the dose for scores of over 8 or those with multiple risk factors, especially those with a BMI of over 35 or those that have cardiac abnormalities or congestive failure. It's very important to increase the dose under those circumstances. Also, depending on the level of D-dimer elevation and the seriousness of illness of the patient, it may be important to go ahead and escalate that dose of anticoagulation up to a therapeutic level. And this is being done around the country and around the world by multiple investigators. We don't recommend routine ultrasound, but only reserve it for those with specific indications that would change the patient's management, such as a swollen leg, pain, tenderness in the leg that are become extreme. And under these circumstances, then a point of care ultrasound could be done. We advocate that the Caprini score needs to be daily reevaluated along with the labs. And then unfractionated heparin or low molecular weight heparin chosen on the basis of clinical situation, including the bleeding risk, and those patients that have organ insufficiency sometimes will do much better with unfractionated heparin than reduced doses of low molecular weight heparin. Although the Wells score can be used to predict VTE, it does not account for all the comorbidities, but it may be useful to guide therapeutic anticoagulation or duplex scanning under certain clinical circumstances. Post-discharge prophylaxis is absolutely critical. Now let us take a look at several recent cases that my partners have experienced regarding this disease. The first is a 90-year-old male who had a non-healing but very painful foot ulcer with an ankle brachial index of 0.3 and a toe pressure of 20 millimeters. The patient was coronavirus negative. An angiogram was done to see if a non-surgical intervention would be appropriate, and it wasn't. So the patient had to undergo a femoral popliteal bypass, which was successful. 40 milligrams of low molecular weight heparin twice a day was used postoperatively, including not only the hospitalization, but following discharge to an extended care 10 days later. So approximately several weeks after the patient's surgery, the patient was readmitted with coronavirus positive, and this was attributed to a healthcare worker at the extended care facility. and the patient needed to be put on a respirator, was given full dose low molecular weight heparin, but to no avail, and died 48 hours later. An autopsy was done and found that the graft was patent. There was no arterial occlusion, and there was no venous thromboembolic event either, but there was. The next patient was a 57-year-old male who had insulin-dependent diabetes, a BMI of 40, hypertension, sleep apnea, and he was a maintenance manager at a nursing home and contracted the virus. He presented with a 3 times normal D-dimer, and the left leg was very dusky from the knee to the foot. Full anticoagulation with low molecular weight heparin was administered, as well as fibrinolytic therapy in 2 courses. A palpable pulse in the groin and popliteal was documented after the fibrinolytic treatment, and this tended to improve during the week of hospitalization with the low molecular weight heparin. Unfortunately, below the knee had become ischemic and gangrenous, and a below knee amputation was done in this patient in the negative pressure OR. At the end of the procedure, the physician dissected the specimen in the OR that was removed. It wasn't sent to pathology, avoiding any additional transfer of the virus. And a thrombosis of all 3 tibial arteries was noted, but the veins were patent. The patient was recovering slowly and the stump healed, but the patient has remained in the hospital as of this writing due to a bacterial pneumonia. So we understand that surgical procedures in COVID-19 patients are very serious, and not only because of the nature of the disease with all the thrombotic elements, but in addition to that, all the risk factors that the patients bring to the table. And as a result of that, an increased incidence of arterial thrombosis, deep vein thrombosis, pulmonary emboli, stroke, or fatal thromboembolic events require careful risk assessment and appropriate thrombosis prophylaxis for the at-risk period, especially following discharge. Now, here is an expression given to me by a Maine friend who was a well-known dentist. And it's never kill a friend, never treat a stranger. Now, what's going on here? What did he mean by that? Well, what he meant was that it's important to perform a thorough history and physical to every patient you meet, so that gives you knowledge about this patient that's the same as your knowledge would be, or even more than a good friend. So, of course, you would never treat a stranger, and you would never hurt a friend. So I'd like to thank you very much for listening to this presentation, and I would encourage all of you to visit my website at venusdisease.com for more information, and have a wonderful day and stay safe. Thank you very much.